Strathclyde in Glasgow, the UK, and Lyon, France. He's going to present the State of Oncology in 2013. This is a new report which draws attention to the urgent need to tackle disparities in cancer care worldwide.
Thank you very much, Cora. Thank you very much for coming along at this unearthly hour of the first cold morning of the autumn. What I'd like to talk about is the State of Oncology. As the discussant to this presentation said, there's 30,000 cookbooks about cancer, and this is the first one that looks at the global picture of cancer. And what we're trying to do is trying to emphasise that there is a global problem, the extent of the global problem, and to look at it in different countries, and then to try and look at some solutions. Just like to say at the beginning, there was 100 people, more than people contributed to this book. They come from, we've got evidence in the book from 50 countries about the state of oncology there. The report is a non-commercial, editorial, independent piece of work. It was funded by my institute, the World Prevention Alliance, an NGO, and we got support from an unrestricted educational grant from Roche to celebrate their 50th anniversary of Roche in oncology. And no one had any influence, no one can have any influence on me when I decide to do something. We go back to 1943. How have we improved? Well, oncology's come a long way. As Professor Lederman was saying, here we've got a new drug that makes a small leap forward, and next year, 2 years, there'll be another one make a small leap forward. And it's all these small leap forwards that have contributed to this changing situation. This is a review that was published in the New England Journal of Medicine in 1943 by Ira Nathanson, and he did a complete review of what was known up to that point about the curability, as he called it, of cancer out to 5 years. And the things to point out are breast cancer with a 22 to 28% 5-year curability rate, prostate cancer with an 8% 5-year curability rate, and testis cancer with a 15 to 53% curability rate. If you look at colon rectum cancer, it's down there about 25–27%. Things have become a lot better now. 90% 5-year survival from breast cancer. In the United States, and it's a huge contribution from overdiagnosis, a 95% survival from prostate cancer. Made huge inroads in the last 15 years into the survival even with advanced colorectal cancer. So we're making huge progress. The problem is that not everyone in the world has got access to that progress or is able to benefit from the progress. And present at the sub-Saharan Africa, they're experiencing a rapid growth and ageing of the population now and into the foreseeable future. And with that ageing population is going to become more and more and more cancer, because we know that the risk of cancer, the risk of developing cancer, increases with age. There's tremendous inroads being made into HIV/AIDS, and then again that's going to contribute, and other infectious diseases are going to contribute to increased life expectancy and a concomitant increase in chronic disease, including cancer. At the present time, the continent is not well placed to deal with the current situation, never mind to try and plan for what's going to happen in the future. The cancer burden in Africa, the incidence will double in the next 15 years in Africa. The treatment infrastructure isn't there. There's 30 countries that don't have a single radiotherapy machine in Africa. Most of the rest of the countries, apart from in North Africa and South Africa, have one machine per country. And for those machines, most of the year, that machine is broken and not workable. They're all cobalt machines, there's no linear accelerators, there's no constant electricity source to generate to support that. We looked around the world and we looked at the ratio of qualified oncologists to the populations. You know, it's hundreds and thousands in some countries, 1,000 per million in some countries. But here we look at places like Myanmar, Nepal, 0.17 oncologists per 1 million population. So how can you expect to treat the cancer burden in a population of 25 million with 0.17 oncologists per million? It just doesn't work out, and you can see the huge variation and the problems that we've got in the low-resource countries with this capacity. One of the things we also looked at, everyone's had the feeling that cancer is more advanced in different parts of the world. Here is the stage distribution of breast cancer around the world. T4 is advanced metastatic disease, T3 is advanced disease, but you look at United Kingdom, Australia, And these aren't in special hospitals, these are just done in non-specialist sort of rural county hospitals. In the United Kingdom and Australia, there's very few patients present at the advanced stage T3, T4. But if you come down to Uganda, Kenya, just about every patient that presents to the hospital presents at T3 or T4 at a stage where cure and curative therapy is impossible and palliation is the only option. And palliation is quite interesting because in 30 countries of Africa, it's forbidden to import morphine, it's forbidden to import opioid drugs. And therefore, when you see patients with AIDS, in the last stages of AIDS and the final stages of cancer, frequently with terrible pain, there is no solution other than paracetamol, and I can assure you that paracetamol is not an appropriate therapy for dealing with terminal cancer pain or terminal pain in AIDS. The conclusions of the report is it's bad to have cancer. It's worse to have cancer if you're poor. The gap between rich and poor, between the highly educated and the least educated, the north-south divide, as we frequently refer to it, is already substantial and it's set to continue to grow. We are making steady progress, continues to be made in all aspects of oncology, and we're moving survival ahead gradually, step by step. But as you can see from the data from 1943 up to the present, all these little steps have combined to make huge leap forwards, and I think that's something to be congratulated for. The big problem is that in the low resource countries, patients present with advanced disease. The case fatality, the mortality rate is very high, and we're not in a position to be able to do anything about that because we haven't really got our act together. They lack treatment facilities, they lack diagnostic facilities, they lack all sorts of backup material, they lack technicians. 80% of cancer in Africa is treated without any pathology or histology available, and that's taking a real shot in the dark when it comes to cancer treatment. We need radical solutions. The Economist Intelligence Unit 4 or 5 years ago estimated it would cost $250 billion just to have everyone in all the resource settings of the world come to the same outcome for their cancer. There's no single source of philanthropy, there's no government, there's no company, there's no single institution that can afford that sort of investment. Gates is making a fabulous investment in vaccination, but even the wealth of Gates and Bloomberg and company cannot come close to making an impact in this overall impact in this cancer problem. I think we need a new model. The current model of financing is broke. We need to fix it. New models are necessary to cope with this situation and the situation to come. There's a need, in my opinion, and this is based on the evidence in the book, there's a need for an effective public-private partnership. I would say private-public partnership because that needs to be driven in the by the private sector. This needs the commitment of governments, non-governmental organisations, as well as the industry, all industry to be effective, and it should have as metric the right of every patient with cancer to have the most appropriate treatment and care for their disease. And each one of us in each institute we belong to have got to really look at themselves and say, go back to what John F. Kennedy said when he was made president, it's think not what your country can do for you, but what you can do for your country. And we should all think of what we can do for the global cancer problem and what our institutes can do and our associations and our organisations can do for the global cancer problem. Thank you very much for your attention.